Welcome back to Physio Vibes. In this video we are going to look at
Colles fracture and physiotherapy management.
Before we start, hit the subscribe button for more videos. Press the bell icon and never miss another update.
Colles fracture and physiotherapy management. It is a fracture of distal end of radius at the corticocancellous metaphysio-diaphyseal junction, with dorsolateral displacement of the distal fragment. It was described by Sir Abraham Colles in the year 1814. Hence, it is known as Colles fracture. Mechanism of injury. Mechanism of injury is by means of a fall on an outstretched hand. The brunt of the force is on the thenar eminence of the palm and is transmitted to the lower radius. This causes the fracture. This injury is commonly seen in elderly, especially in women with osteoporosis. Diagnosis: pain, swelling and deformity of the wrist. Tenderness and irregularity of the lower end of the radius is found. There may be a typical dinner fork deformity. The radial-styloid process comes to lie at the same level or a little higher than the ulnar styloid process. Radiograph. Plain X-ray of the wrist. Lateral views are recommended to make an accurate diagnosis. Treatment: non-operative. Closed manipulation and reduction under general anesthesia followed by immobilization. Plaster of Paris offered the below elbow cast. Duration of immobilization is 4-6 weeks. Operative. Surgery is done in the form of closed Kirschner wire fixation under C-arm. Image intensifier control when there is dorsal comminution and articular surface involvement. Complications: malunion. In malunion there is a deformity. It is treated by corrective osteotomidothorax procedure. Delayed union and non-union managed by means of bone grafting with or without internal fixation. Subdex atrophy and shoulder-hand syndrome managed by physiotherapy and adequate drugs for symptolysis. Carpal tunnel compression of median nerve. Carpal tunnel decompression is the treatment advocated. Extensor pollicis longus tendon rupture reconstruction by means of tendon transfer using extensor indecisus the donor tendon. Physiotherapy measures for Colles fracture. During immobilization, the hand is elevated above elbow above shoulder to drain the excess lymphatic fluid from digits. Full range passive as well as strong active movements of fingers are done. According to Alon's, the use of electrical stimulation on sensory excitation level creates an electrical field in tissues which triggers the lymphatic system to absorb excessive fluid. According to Sorzan, the use of pulse galvanic stimulation can reduce edema by stimulating the pumping action of muscles. During immobilization, intermittent pressure glove biceps helps to reduce edema of fingers, thumb by piling a pressure not more than 66 to 70 mm of Hg for 45 min to 1 hour. To the fingers exposed metacarpals volar pads can be wrapped with string to reduce edema. Elevation of hand can be maintained at with 70 degrees of flexion at elbow, using a sling, thus reducing edema. Other methods like infrared, hot packs, chyotherapy with ice massage TENS are used to reduce edema. On removing the plaster 3 to 6 weeks, a soothing effect is given by hydrocollator pack or paraffin wax bath. Induces relaxation, improves circulation. Wrist mobilization is initiated with small range of relaxed speedy flexion extension with forearm in mid-prone position. As the wrist is immobilized in ulnar deviation, so radial deviation movement are taught to counter the persisting edema pain. If present, then an intermittent sling is given. To further increase the rheumatist forearm after 1 week, Exercises to improve supination and pronation flexion extension at wrist. Exercise regime is made vigorous using aids like wand, table edges, etc.
Thanks for watching. Don't forget like, share and subscribe.